Good afternoon and welcome to the City Club of Eugene's June 28th, 2024 program, First Do No Harm, the State of Healthcare in Oregon. My name is Andrew Kallick and I am City Club's president. We're coming to you from our home at the 5th Street Market in the heart of downtown Eugene. It's my pleasure to extend a warm welcome to our speakers and to all of you joining us right here in person, online, and over the radio. For 3 decades, the City Club of Eugene has remained dedicated to its founding mission to build community vision through open inquiry. In accordance with our mission and purpose, we hope to help connect people throughout our community and across identities, generations, experiences, and perspectives. You are invited this week and every week to join us in this effort, to share your wisdom, to learn something new, and to take active steps to make a difference in this city and region we love. Of course, we cannot do this work alone, so a special thank you to our Platinum, Community, and Diamond sponsors. The Eugene Area Chamber of Commerce, serving as a catalytic leader in creating a vibrant and diverse economy that drives economic opportunity and well-being. Kaiser Permanente, which exists to provide high-quality, affordable healthcare services and to improve the health of our members and the communities we serve. More information at www.kp.org. The University of Oregon has helped Oregonians question critically, think logically, reason effectively, communicate clearly, act creatively, and live ethically since 1876. More information at uoregon.edu. Lane Community College transforms lives through learning. LCC provides comprehensive, accessible, high-quality educational opportunities that promote student success. For more information, visit lanecc.edu. And thank you to the City of Eugene and to Lane County for their support as well. Whether you're joining us for the first time or you're a longtime listener, I invite you to support our work by becoming an individual member, a business or community sponsor, or by volunteering to be part of one of our committees. You can do all these things and more at cityclubofueugene.org. Now, today's program is the first in a series on Oregon's healthcare system and what local governments, the private sector, and nonprofit leaders are doing to tackle some of the biggest challenges we face. We're fortunate to have Representative Nancy Nathanson, one of the state's leading voices on healthcare, here with us today to moderate our discussion. Representative Nathanson has been working hard to address the critical challenges facing the state's healthcare system, including those generated by consolidation in the primary care space, which we'll talk quite a bit about today, as well as the closure of Peace Health's University District facility. Among other efforts, Representative Nathanson led the fight during this legislative session to pass HB 4136, which allocated $4.5 million to emergency care needs here in Lane County. She continues to collaborate with colleagues, including Oregon House Majority Leader Ben Bowman, who will be joining us for part 2 of our conversation next month, to ensure that Oregonians have access to health care. Representative Nathanson, welcome back to the City Club of Eugene.
Thank you very much for the introduction. Hello, everybody. This past winter, I saw a panicked note on Nextdoor, that social media app that some of you may use on your phone or computer. Someone was asking for help finding a doctor. They could no longer get care from Oregon Medical Group. There were a handful of replies to that post. In the next couple of weeks, there were more posts, some of them with a dozen or dozens of replies. I could see that something with dire consequences was developing very rapidly. I started making calls to Lane County Medical Society, the State Medical Board, the governor's office. I did a news interview, and after that, more people started contacting my office, letting me know exactly what was happening. Meanwhile, I am still continuing legislative conversations with stakeholders. A few examples of what I heard from people. Self-rationing prescription medication for diabetes, for Parkinson's disease, because they didn't have a way to get a refill and didn't know when they'd be able to get help. This was dangerous. A mother whose annual wellness checks for her children had been canceled, along with their routine and required immunizations. In an unfortunate coincidence of timing, our community was starting to experience the beginning of a pertussis outbreak. Alas, many had also not even been notified by Oregon Medical Group. No letter. They found out when they tried to make an appointment that they no longer had a doctor. People were scared, they were anxious, they were angry. Part 2 of this series next month will take the conversation up to the 30,000-foot level, learning how healthcare in America and Oregon has evolved, how our financial climate and law influences the organization of healthcare, and how they can be used to reshape the structure and delivery of healthcare. Meanwhile, today's focus is on Oregon Medical Group and on patients. We're going to hear from people who know about this from the inside, as caregivers, and who understand things from the patient's perspective. Dr. Mark Lichman is a retired family physician, a former president of Lane County Medical Society, a founder of Oregon Medical Group, and its president for a decade. And I was his patient until he retired. Xin Tang is a licensed psychologist, a psychology instructor at Oregon State University, and the clinical director of the Oregon Mind-Body Institute, which promotes mental health education. With Dr. Jennifer Fried at the University of Oregon, she has co-authored research on betrayal trauma. Dr. Tony German is a practicing family physician. He is the founder of Salud Rural Maternal Child Health Fellowship, which prepares family physicians for practice in a rural or underserved setting. He brings those perspectives to his role as a member of the very important Oregon Health Policy Board, which provides oversight over the Oregon Health Authority and major health systems, including the state's Medicaid program, Oregon State Hospital, public health, behavioral health, and major health insurance plans for public employees. Dr. Lichman, you're first.
Thank you, Nancy. Yes, I'm Mark Lichman. I am, as Nancy said, a retired family practitioner. I was born and raised in Eugene and came back to Eugene after my training. And after a year working in the emergency room, I joined Westmoreland Clinic in West Eugene in 1979. There were 7 family practitioners in the clinic, and after 9 years in 1988, the 7 of us joined with 2 other family practice clinics and 2 internal medicine clinics to form Oregon Medical Group. There were 27 of us in total. Oregon Medical Group was formed to address the changes going on in medicine in the 1980s. Capitated HMOs, or the Health Maintenance Organization movement, was in full swing. We believe that by combining forces, we could better address the technical demands that were presented by the marketplace. By pooling our resources, we could acquire more sophisticated administration that none of us could afford individually. Health maintenance organizations were a new phenomena for physicians and patients. It introduced both capitated patient care to PCP groups and formal referrals to see specialists. The doctors in the new OMG wanted to continue the tradition of excellent care that the 5 medical groups brought with them, and also help our patients navigate the increasingly complex landscape of specialty care. Initially, the group grew by adding a local pediatric group and an OBGYN group. By the time the group of primary care doctors got to be about 50 or 60 physicians, we started adding non-primary care specialties. Our criteria for adding a specialty was, were our patients having difficulty with getting access to care, timely care in a particular specialty? And also, can the specialty help economically support the success of OMG? Because we felt access to care was an important principle for the group, we built additional neighborhood clinics in South Eugene, Churchill, Bethel, Sheldon, North Eugene, and Springfield. Our ads on the TV told the community that we were in their backyard. We developed an evening clinic and weekend clinic that was staffed by the regular primary care doctors in OMG. We later started 2 immediate care clinics that were open 12 hours a day and 7 days a week. Our goal was for a patient who felt like they had an acute need to be able to be seen that day or the next day, either by their doctor, another doctor in their clinic, another doctor throughout the system, or our after hours or urgent care offerings. During this time, OMG grew from the 27 founding physicians to over 125 providers and greater than 500 staff, and became the second largest provider of medical care in Lane County. During these exciting years, I was active on the recruiting committee, and later, as Nancy said, served as president for 10 years. This gave me an opportunity to meet with many prospective new physicians who were interested in OMG. At these meetings, I would stress that they should closely look at Oregon Medical Group because we were an independent physician-owned group. We had professional management that worked with active physician committees to run the group and set the course for the future. And the physicians had a fair amount of control over their day-to-day practice life. And I emphasized that we had a high physician retention rate. When I went into practice in 1979 at Westmoreland, I would see my patients early in the morning in the hospital and then go to the doctor's dining room to have breakfast. The older doctors there would complain about the changes in medical care. They yearned for the good old days. Over the next 40 years, I too saw many changes in the science of medicine and the way we practice. In 1978, less than 10% of physicians in the United States were employed by hospital health systems or other corporate entities. According to the Advisory Board publication, by the end of 2023, that number had risen to over 77% of physicians in the United States being employed by those entities. There are many reasons for this shift, including the vastly more complicated practice management landscape, student debt, and changing lifestyle goals of more recent graduates. During this time, OMG sold itself twice, but we found that the loss of physician control was not what we wanted, so we bought ourselves back. It became apparent to us that the way to continue to give excellent care and remain economically viable was to standardize office practices and physician schedules. OMG needed to continue to adopt more sophisticated computer medical record systems. We found that although these efforts were necessary, they were very challenging to carry out. I retired in January of 2020. I truly enjoyed working with my patients, the staff, and fellow doctors of OMG. I'm very proud of the work that 27 founders and the physicians and staff that followed built in this community. Thank you very much.
Good afternoon. I'm Dr. Xin Tang, and it's an honor to be here with you all. I'd like to think of myself as a homegrown psychologist. I received my doctorate in clinical psychology here at the U of O, and hopefully that makes up for my being a California transplant. I had the good fortune at the U of O to work with Dr. Jennifer Fried, who was my graduate advisor and the developer of betrayal trauma theory, which I'll address today. So I'm grateful for the opportunity to talk a little bit about the emotional impact that many experienced when they lost their primary care physician at OMG. And Representative Nathanson mentioned a few of these stories, and I'll share a little bit more. And I think loss is a really key term here, because although OMG is still operating, of course, our community has experienced a great loss in its recent sale a few years ago, and of course the subsequent departure of 32 doctors in the last couple years that left potentially tens of thousands without a medical home. It's important to note that a number of those physicians who left have cited unmanageable patient loads coupled with increased administrative duties as primary reasons for leaving. I also propose that all of us, even those who haven't lost a doctor, have suffered a loss marked by the increasing corporatization of healthcare. The mass exodus from OMG is part of a greater nationwide trend, as we've heard. How can we know our doctor won't be next? Human beings are hardwired for connection. Therefore, when we lose key relationships, whether it's with an individual or an institution, or both, we lose a sense of safety. As Oregon Public Broadcasting reported last year, the loss of a doctor means the loss of trust in the entire primary care system. Betrayal trauma research can help explain why this is and the harm that this loss of trust may cause. My hope is that in being able to name how we feel and why, we can better grieve what we've lost as a community. As I teach my students, taking the time to feel one's full range of feelings can be a radical act of resistance and healing. So today we have a valuable opportunity to acknowledge our losses, identify how we feel about them, and give voice to these emotions. So I spoke with several of my friends about how they felt about recently losing their OMG doctor. Shock, panic, and anxiety were a few of the words one person used to describe his reaction when he called OMG to schedule an appointment, only to find his primary care doctor had already left. While he has been accepted as a patient with another local clinic, the wait for an appointment is several months, and he has still not received treatment for an urgent medical condition. Another friend had her medical appointment canceled on the same day she was going to be seen. As a result, she didn't receive care that could have identified a kidney infection before it became life-threatening and required hospitalization. It terrifies me that she could have died over something so preventable. More than one friend had to scramble to get prescriptions filled through their gynecologist. A common theme throughout these stories was feeling betrayed by the institution they trusted with their well-being and the loss of safety that having access to medical care provides. What happens when an institution we depend on betrays our trust? This is a question Dr. Fried asked, predicated on decades of groundbreaking research on betrayal trauma. Research that demonstrated the fundamental role of relationships in explaining how trauma does harm. According to betrayal trauma theory, trauma experienced at the hands of someone we are close to or dependent on has the potential to cause more harm when the perpetrator is someone we are not, or we are close to, or versus when the perpetrator is someone we're not as close to. For example, child abuse and neglect perpetrated by a parent or guardian can cause more psychological harm than by somebody outside the family, like a neighbor or a coach. Though it makes intuitive sense, until Dr. Fried began this line of research, little attention had been paid to the role of relationships and betrayal in psychology, and instead focused on pathologizing victims. However, studies have repeatedly found that trauma with a high degree of betrayal can result in more severe symptoms of post-traumatic stress, depression, anxiety, and than those in trauma low in betrayal. And even though an institution isn't a portion, of course, we develop relationships with the institutions we depend on, such as schools, places of worship, government agencies, and of course, hospitals and clinics. These institutions, in fact, tell us they will protect us, and we depend on some of them for with our very lives. Dr. Fried and her research team found a similar pattern of risk and harm when it comes to institutional betrayal trauma as they did with other forms of betrayal. Feelings of shock, panic, and anxiety, as my friend described, are typical and all signs of feeling unsafe. So not everyone will have been traumatized by losing their healthcare home, with few options of finding a new one. But it is fair to assume that it has significantly increased the stress levels of many, especially as our brains don't like uncertainty. It's also painful to feel uncared for, particularly by health care. Therefore, institutional betrayal can still be a useful term, regardless of whether one felt actually traumatized. Institutional betrayal is not often intentionally malicious, which is what makes it difficult to identify and name sometimes. More often, it's more of a reflex to protect the reputation or the existence of the institution at all costs. So those who were betrayed may not even feel a sense of betrayal at first. The protection of the institution can take several forms. The first is the failure to prevent harm. Second is normalizing that harm. For example, the institution might say they didn't have a choice, or they may make the victim feel as if they were at fault. And third, there is an inadequate response to harm. So a lack of willingness to provide meaningful help. Recognizing these dynamics can be helpful in understanding why a strong emotional response is valid when it comes to institutional betrayal. So if institutional betrayal is the problem, according to Dr. Fried, there is hope in institutional courage. She defines institutional courage as an institution's commitment to seek the truth and engage in moral action despite unpleasantness, risk, and short-term cost. A growing body of literature shows, such as our government, to act with courage by protecting our healthcare access, which Dr. German will tell us about next. Thank you.
Well, nice to meet all of you and be here today. And thank you so much for the members of the Eugene City Club. My name is Tony German. I use he, his pronouns. And as mentioned, I'm a family doctor. And I practice in the Willamette area. I'm an educator for family doctors to practice more in a rural setting. I also serve on the Oregon Health Policy Board. And I'm Vice President of Healthcare for All Oregon. I believe my invitation today resulted from my involvement and participation in advocacy to bring greater agency to healthcare professionals. And most importantly, my interest lies in creating better outcomes for my patients and my community. Today we listened to Dr. Lichman give a really lovely history of the Oregon Medical Group, serving a local community with local emphasis and attention. However, delivery of healthcare is becoming less and less local. And part of our discussion today, I believe, will surround where healthcare delivery is going for the future. And I think we should be attentive to the question, is it going in a direction that we want it? Do we believe that healthcare access and outcomes is improving for your family member? And how is that changing for their outlook for them in the next year or the next 5 years? Retrospectively, when we look over the last 14 years, since our last major healthcare reform with the Affordable Care Act, the truth is more people today cumulatively forego medications and treatment than when the ACA passed in 2010, despite more people having health insurance. Yet healthcare spending growth is expected to outpace that of the gross domestic product during the next decade. It's going to result in a share of GDP that's going to reach 19.7% by 2032. Healthcare is a unique consumer good for which individuals can only obtain that good because it's subsidized. We subsidize this for the poor with Medicaid, elderly with Medicare, the military with the Veterans Administration. Employer-based insurance is supported by tax exemptions, and the individual market of the ACA with tax premium reductions and cost-sharing reductions. So where is all that money going when other developed nations can provide a collective contract with their citizens to ensure people get the care they need when they need it? And they do it for half the price. So Jinshin gave a wonderful introduction to this, and I want to step over to something that's really important to me, and that is trust. We know how important that is, trust in a healthcare setting. I have observed this for the entirety of my career, but it especially became very evident during COVID. Individuals are more likely to engage in a treatment plan or vaccination if they have confidence in your counsel. In a recent IPSO poll, 2 out of 3 patients, 68%, say trust in healthcare has declined in the last 2 years. And the top reason patients feel trust has eroded is born in the feeling, and I quote, "The healthcare system acts out of self-interest rather than mine as a patient." In another poll, roughly 9 in 10, 87% of US doctors said that patient trust in the profession is eroding. Another concern of mine is burnout among healthcare providers. For over a decade as a medical director, I have witnessed cohort after cohort of providers and staff enter our clinic walls with best intentions to improve the quality of life of their patients, which I argue is the reason they enter the field. Then they come up against the reality of what the US healthcare industrial complex has in store for them. Some have left the field, most have reduced their hours, some retired prematurely, and numerous have taken leaves of absence. This all is occurring on top of our healthcare workforce shortage. A more important term of these responses is moral injury, and which has been defined as being forced to act in a way that transgresses one's values and beliefs. Physicians and healthcare providers are trained and committed to an oath to put their patient first. Yet most recently, these caretakers are forced to navigate the demands of other stakeholders, including corporate employers, insurers, hospitals, regulatory agencies, and the pharmaceutical industry. This negotiation between all of these stakeholders often is in conflict with the provider's perspective on what is optimal for the patient, best interest, and what's evidence-based. The ethical pathway of all these competing interests is exhausting. Fundamentally, I believe this is the origin of the emotional fatigue and the loss of resilience among my colleagues. Hence, we find 63% of physicians report burnout in a 2020 poll, an all-time high. My leading concern in healthcare is the corporatization of the field and the insatiable drive of a profit-driven motive. The focus of the health field has changed from serving the needs of a patient to generating money. This comes as a trade-off to health outcomes and to this workforce. My role as a provider is to make observations and advocate for my community, patients and staff, and a few items I'd like to highlight today. The corporatization of healthcare demonstrates concerning trends in patient outcomes. Studies have found a statistically significant increase in hospital readmission rates following acquisitions by corporate systems. One analysis found that 2 to 3% increase in readmission for Medicare patients. Over the last decade, hundreds of hospitals and thousands of physicians and many additional healthcare entities in the US, including specialty care, primary care, hospice, nursing homes, and ambulatory surgical centers, have been acquired by private equity firms, emerging into larger health systems. Private equity investors spent more than $200 billion on healthcare acquisitions in 2021 alone, and $1 trillion in the past decade. In 2023, 65 hospitals or health systems in the US announced transactions regarding mergers or acquisitions, and the transaction revenue was a lot of money. A recent study showed that 13% of metropolitan areas in a single private equity firm own more than half of the physician market for certain specialties. And as Dr. Lichman alluded, that there is a great majority of physicians, about 77%, that are now part of a larger health system and entity. Another concern is the insurance industry's corporatization. With the leader of this trend, of course, United Healthcare and subsidiary Optum. And as mentioned, 1 in 10 physicians work for under Optum, about 90,000 providers. So this is what keeps me up at night. But I think there's a lot of good news, and I think there's some really good bright spots in Oregon. And first off, I really want to thank Representative Nathanson for her attention to these issues in this community and remaining focused on what's going on locally. I'm proud to be a participant in an effort to yield greater agency to our profession working with Rep. Bowman on the prior session's House Bill 4031, a bill prohibiting the corporate practice of medicine with the intention to bolster the autonomy of healthcare providers, ensuring decision-making is based on a trusting relationship between a patient and their provider. This legislation can empower health providers and support patients. Additionally, our state is one of a couple that has passed legislation to give greater scrutiny to mergers and acquisitions, the Healthcare Market Oversight Committee, HCMO. Under the direction of the Oregon Health Authority, it remains in its infancy but continues developing tools to hold corporations and businesses accountable to service in their communities. They serve as oversight to allow or deny if a merger can proceed. These reviews often incorporate a community review board. Let's ask the community affected by changes in the health infrastructure how this impacts their community, and also must ensure that we must ensure that HCMO is performing its responsibility in doing its due diligence in these reviews. As mentioned, I serve as Vice President of Healthcare for All Oregon. We are the leading health policy advocacy group in the state, paying attention to healthcare affordability, concerns, and coverage, and pharmaceuticals, and pressing our state to move to a universal healthcare system. I encourage you to take a look at our website at hcao.org and become part of our movement. Lastly, I would encourage all of us Oregonians to continue to learn about the changes that are occurring in our health system. Continue to ask the question if consolidation in the health sector is producing the purported outcomes we are told, or have they led us astray? Thank you.
Thank you all so much. We'll be back with our Q&A in just a moment, but first I'd like to thank the business and in-kind sponsors whose support helps to make City Club possible. Thank you to our gold sponsors, Network Charter School, Hirschner Hunter LLC, Evans Elder Brown and Subert, Luvis Cobb, and Hudson Dental. Dr. Hudson is in the room, by the way. How cool is that? We have sponsors who come here and they love the content too. Thanks, Doctor. Thank you also to our in-kind sponsors, KRVM 91.9 Radio, Alpha IT, Dotson's Photography, and Kid Sports. Also a special thank you to our award-winning public radio station KLCC FM 89.7 for airing City Club programs Monday nights at 7 p.m. For those listening at home or in the car right now, your household is one of several thousand tuning into City Club on KLCC, and we love that you're here. You can find all recent City Club programs archived on KLCC as well as on our YouTube channel and as podcasts. We'll take a brief break and get back with questions. Thank you. Welcome back to the City Club of Eugene and part one of our series on healthcare in Oregon. The first question today comes from Representative Nathanson.
Thank you. My question for the panel. The program description refers to a centuries-old oath, first, do no harm. A physician's duty of care for existing patients is an important principle, it's a responsibility, and it's the law. Thinking of duty of care and medical or patient abandonment, what are your thoughts on legal obligations? Should these responsibilities rest solely with a physician, since doctors are no longer necessarily the chief decision maker in the type of care received by a patient?
Well, yes, there are other factors that go into the interaction with a patient in a room, but I would suggest that the vast majority of physicians still focus on doing the best for the patient and helping the patient and the doctor work around any obstacles that come up in providing that care based on the mutual decision.
I'll just speak briefly from the perspective of someone who owns a private practice in mental health, and I think we see the very same trends in mental health as well. It's becoming increasingly corporatized. And as far as doing no harm, I always tell people, and it's harder to take your own advice, but to put your own oxygen mask on first. So to me, first, do no harm applies to healthcare providers as well. And I think that's an important thing not to lose, as Dr. German mentioned in Doctor Mental Health. Okay.
Certainly an easy question out of the gate, Representative Nathanson. I come at this as, we just went through a walkthrough of where we are and the constructs of where people work. And, I think when a patient enters my clinic setting, yes, my duty is in that setting at that time point to do the best for my patient and do no harm and do the best I can. I think we do need to take a greater perspective of the larger landscape where we find healthcare right now. And so I do think that, again, going to other societies, it's a community approach to care. Here we're making it very individualistic in locally and in our state. And I think that our health systems are part of this equation, right? But they are so siloed and not working, very well. We are not including, our aspects of public health. That one health system has to do that. This one has to do that. And I think that we could work more constructively if we thought at the larger picture. And so, I think in an individual clinical setting, yes, my duty is to make sure that the optimal outcome of that patient that comes to see me that day is going to get the best care and do no harm. But I think we certainly can do better.
Next question.
Thank you. My name is Lou Siniger. I'm chapter chair for Healthcare for All Oregon in Lane County. I have noticed acquisitions and mergers and even closures. We recently lost an emergency hospital in Eugene, and very little has been done. Nancy Nathanson has given a great approach to kind of try to fix things. What I've noticed is that our medical community is run on a business model rather than a health model. And this is threatening our community, total health. So my question is there anything that the state of Oregon is doing to try to get this into a health model rather than a business model?
There are a lot of, medicine is very complex. The healthcare setting is incredibly complex, and I think that's my point that I was trying to make today, is growing more and more complex. There are a lot of smart thinkers in this state and across this nation that are trying to solve this complex equation. But I think it is rooted, Lou, in your comments that when the set of rules and the game board, if you will, that we're playing is set for a motive where it is derived from the function that it's trying to optimally obtain right now is a business model. And it is a model where it's trying to extract the most dollars. And I don't fault administrators. I don't fault certain systems that are doing that. They're doing what is their fiduciary responsibility, right? We do need to provide pressure, and I think that's part of what our efforts are at Healthcare for All Oregon, is to bring forward that idea, right? That we have to continue to put pressure on the decision makers at our State House and at every level, right, to alter the game that we're playing, because we will continue to play this game, and we're not really moving the dial. As I mentioned, we are subsidizing care, and what we are doing is we're bringing access in the form of certain programs. We've decided to do a program for really expansion and a number of things in the state. This state has done a phenomenal job of moving uninsured. What we are challenged with is underinsured at this point still, right? And we're seeing a growing gap where we're giving people health insurance, but their deductibles and their copays continue to go up. And in essence, their challenge and ability to get care is with that. So I think we still need to continue to put pressure on decision makers about that model.
I don't disagree with anything excuse me, this is for the radio audience, this is Mark Lichman. I don't disagree with anything that's been said here, but I would suggest to you that business is a medicine, medicine is a business and not just a cottage industry. In order for Oregon Medical Group, over the 40 years that I was associated with it, we brought many new clinics and a whole lot of new doctors to the community to provide service for all of you. However, those new clinics and those new doctors and the 500 or so staff that supported them all had costs associated with them. So if you bill $1, a good primary care clinic has overhead of 55 to 60 cents. I believe that Medicaid pays about 30 cents on the dollar billed. Medicare pays about 40 cents on the dollar billed. Regular commercial insurance, if you have a really good contract and a sharp negotiator, pays about 75 cents on the dollar. So nothing is free, and so there is business in medicine because you have to keep the doors open. If you're going to have a urgent care that's open 12 hours a day, 7 days a week, or you're going to have enough doctors to see all the patients who want to come in, there's overhead associated with that. So you can't just ignore the business of medicine.
Next question.
Hi, my name is Kellyanne Stiles, and I'm a member of Junior League Eugene and the mother and grandmother of victims, survivors of sex trafficking. So my question is, what are the resources that you now have available to have all the medical staff and those involved trained for sex trafficking awareness, to recognize the red flags? And are you aware of the resources that are currently available, city, state, and nationally and federally, to rescue the victims and get them wraparound services so that they can be rescued and to rebuild their lives?
I'll answer that first. This is Mark Lichman again. I retired 4 years ago, and at the time, I don't believe we had any of those services.
This is Tony German. I think one of our clinics focuses on inclusion of a team-based care approach, and understand the importance of physical and mental health, and attention to when we have victims, and paying attention to certain signs. We've had certain number of people come into our clinic in presentations outlining areas of concern, certain red flags and things of that nature. And so we've had some educational seminars on that, but I think pairing that with the victims themselves, with mental health services and on-site behavioral health and connection with our mental health colleagues.
Joel Corin, City Club member. I have a question from the doctor's perspective. Since there's been corporate takeover of OMG or other groups, how has the takeover affected the doctor's day-to-day life in terms of the number of patients they see, in terms of the other things that they have to do? And secondly, is there betrayal trauma for the doctors that have undergone this takeover?
So I'll speak to a number of observations that have been occurring. So with respect to, there's a couple flavors on this. So we have private equity's entrance into this healthcare landscape, and then we have corporate approaches to this. And the goal is to be efficient, right? And with efficiency, as a business, as our coalition alludes, is that there is certainly a huge component to healthcare. That's a day-to-day operations. It has to be a business. It is a business, right? But what I would call out is the concern of how much we're extracting from that system in the area of revenue creation for profit, right? And there's been a greater drive for that in the last 10 years, 20 years. And so with private equity's entrance into that is there is a lot of money that comes in and purchases a business. The intention in private equity is return on that investment at a quicker pace. Oftentimes those are at the scale of a few years. That could be 2 to 3 years or 5 years. In order to accomplish that goal, you have to make cuts. And cuts come in the form often in the space of staffing, the resources that are provided in a clinical setting, the types of things that you can do, and then you pressures that are placed for, so we have a lot of, getting into some weeds, we have vertical integration and we have horizontal integration or consolidation. And so there are a number of different pieces, but what I'll keep it simple is that you are taking away a lot of the resources of staffing, and hence what happens is you have providers with more patients to see. You have a higher level or a lower level of skill set in those settings. So you might transition from a provider in this setting to somebody that has a lower skill set with that. And so in instance in like nursing homes, right, or in hospice care, you have fewer qualified people in those settings. And so that work gets pushed onto a smaller number of people. And that leads to a set of burnout, right? If you have to do more work with less resources, you're going to be traveling down this road of what I was talking about moral injury and burnout. So I'll leave it at that and see what other.
Hi, I'm Mark Litchman. One of the joys of my practice of family practice over several decades was getting to talk to the patient and deal with not only their health problems, but their dahlias and their grandkids' soccer tournament and all those sorts of things. I think the thing that stresses physicians a lot is when other things get in the way of those relationships, like having to poke so many buttons on the computer so that you can't spend time talking with the patient, but you have to be filling in the blanks on the computer screen, and that slows you down significantly. So unless you stay way late into the evening, you cannot see as many patients in a day. And so the computerization of medicine, although it has some good points has also reduced productivity and doctor-patient relationships as far as I'm concerned.
Dr. Tang, do you want to address the institutional trauma portion of that question?
I was a little hesitant to because I haven't spoken with physicians personally about this from OMG. I did some research for this presentation today and finding testimonials in the news about that. And I think we'd have to ask the physicians themselves if they've particularly experienced trauma. I know it can be a term that's often used, sometimes overused, but again, I would refer people back to feeling definitely a sense of stress, and some can very well argue there's a sense of betrayal here. And so the one thing I think hasn't been addressed also, again, coming as a mental health provider, is feeling a similar sense of stress in terms of the way business is conducted. Yes, it is a business, but I think the way that insurances are increasingly scrutinizing mental health billing and really makes private practice providers like me not want to do it anymore because it's safer to work for a group or a corporation, because of an increasingly common practice is, for example, clawbacks. The official term, I think, is recoupment. And there's a House bill, and I wish I knew the number of it, but that's hopefully will pass, that protects mental health providers from these clawbacks that can basically be as far as years ago as it currently stands. So you could see a patient, and what that means is the insurance can decide 3 years later that you didn't do it right and take that money back. So that's what keeps me up in my practice, and this is a source of stress and risk to my personal well-being and my family. So, I think protecting how we do business is an important part that our legislature can do.
Thank you.
Sharon Reed, City Club member. I'm wondering if you are seeing on the side of patients or the side of doctors a growing interest in concierge medicine, so that those people of means are choosing then to leave the more corporate and paying, let's say, the entrance fee and the monthly retainer to have a doctor whom they can call, daily, and for that very personal touch that you were talking about.
This is Mark Lichman. When I, in the last few years of my practice, I occasionally ran into somebody who had joined one of the few concierge practices in Eugene. I now live in Portland, and I have run into more patients or more friends who now participate in that, but I would not say it's a large number.
Tony German, thank you for the question. So many pressures and so many things to do in clinic walls, and as I mentioned, having to pay attention to all the stakeholders is exhausting. I do not fault anybody that wants to spend more time with a patient in a quality visit and design their own business and be an entrepreneur to go forth and create good outcomes for that patient and that collection of people. I think that's great. I think they're being thoughtful and supportive of their own health, and I have a number of colleagues have done that. The piece that I think that we need to answer for that is a lot of that is in a clinic walls, and then when a patient needs help outside, a lot of that is through their negotiations to get imaging, to get follow-up care if they need, those connections with specialty care. I do worry about that coverage for somebody that gets into a car accident or that has cancer that doesn't have that full next step for insurance. I worry about what those costs will be, and so those are things I think about and consider. But going back to, I think, what is pushing people in that direction is the multitude of things we have to account for. We are trying to be attentive to population health and in a lot of clinical settings, in a primary care setting I will speak from. And so I have a litany of 150 things to think about in a clinical setting for that one patient coming in that day, for preventative health care, the billing codes, the pharmaceutical scripts, how that's going to be covered, what type of insurance that's going to be covered with. They have this plan, and there's over 100 different commercial insurers that are through my clinic walls. The easiest one is Oregon Health Plan. I kind of know that, and that's a bulk of my patients. So I know that if I order that medication, it's going to get covered. I know that it's going to sit there for a week because it has to go through a prior authorization. I'm going to get a multitude of things in my inbox, and I think a lot of people are coming up to this question is, do I want to practice medicine this way? And I think the answer is we're just seeing, I think it is a smaller amount, as Dr. Lichman alluded to, but we are seeing a growing trend of people making that decision for themselves to practice in that type of setting.
I also want to add, building on what Dr. German said in his talk on physician mental health, that again, we can't fault these people for doing it and taking care of themselves when rates of anxiety, depression, and even suicide among physicians are so high. I think it's important that people are able to find a way to practice in a way that supports not just their preferences, but really their well-being and their ability to practice at all.
I'm Ralph Pledger. I'm a member of the club. I use OMG as my provider, and recently I went online to make an appointment for a routine physical, and I learned that I wouldn't be able to see my doctor, but I'd be seen by a physician's assistant. My initial response was irritation, maybe a little more than that, but thinking about it, I came to the tentative conclusion that this might be quite rational. So what's your take on that?
This is Mark Lichman. The advent of physician's assistants came about while I was practicing medicine, and it was born, I think, at least partly out of why we're here today, and that is that there are only so many physicians, and they can only see so many people a day. And so these physician extenders have become very necessary in the community, and some of them are very talented and well trained, and I think you're probably well served if your clinic has those people.
Just to add on, this is Tony German, add on to that. My clinic is comprised of half physicians and half advanced practice clinicians that are nurse practitioners and physician assistants. And I highly value the work of my physician assistants and nurse practitioners. They are really bright and have a great amount of training as well. I think it is really just determining the level of training. We all have a scope of practice, and there are certain things that some of us might have more experience in. So we are a team-based clinic. We have moved towards that incorporation. I think I value my dietitian as well as I value my behavioral health colleagues, my mental health nurse practitioner. We are a team. There really isn't a difference between us, and I think medicine has moved towards this and understanding that there is a shortage in workforce and that we all have a place to contribute in the setting of a clinical setting. So I would highly promote you continuing to seek care, and I think you will get value. I think one of those is understanding people where we know we've reached our limit of expertise, right? So in instance, I'm a primary care doc. At some point, I'm going to need some specialty care. I'm going to need to refer you to somebody. If you break a bone, you're going to the orthopedist, right? If you have prostate problem, you're going to the urologist, right? And so I think that just an understanding of those that, you know, I have worked along some colleagues for greater than a decade, and I highly support them and the work they do and value the work that they do in that setting.
We have time for one more.
Hello, thank you all. My name is Rebecca Sprinson, and I'm with Food for Lane County. I'm also an Oregon Medical Group patient. And when I heard that OMG was closing my local clinic, I experienced all of the concerns that Dr. Tong described. However, I have many community and personal resources to either drive to a distant clinic or navigate having to find new health care. A huge percentage of our local neighbors don't have those types of resources. They're already stretched very thin, meeting their day-to-day basic needs. What specific actions can we take locally to help families who don't have resources like I do navigate the dearth of services available to them or the closure of clinics that they've relied on? Thank you.
Yeah, you know, this is Tony German. I don't practice in this region, so I can't really contribute a ton to that. But I think of ideas is, again, us bringing a focal point to what is occurring in this community. What has happened with this clinic that you trusted and were connected to? I still think that, you know, reaching out to resources that they might offer, right? And putting pressure on that, I think speaking with our representatives here, right? I think speaking to, you know, there are other resources that I think in the broader spectrum, like senior services, thinking of OHP, thinking of connection with that. Some people may be, certainly if you are falling in those categories of care, what you have covers in there are resources through the state that can reach, so such as the Ombudsman program for Oregon Health Authority. So I think of some of those as the greater, but I'd be interested to hear locally.
I can just speak locally to mental health as part of healthcare. It may take time, but I think the state is really looking into decreasing hurdles to licensure for new therapists, which I think is a really positive thing to do. So we can, and they also have been, speaking of subsidizing OHP in terms of mental health care.
Since this is Mark Lichman, since I have not been part of OMG since Optum took over, I can't speak specifically, but I can, from what I know, when you lose a bunch of doctors and you have all these facilities, you know, you end up with a lot of empty offices and exam rooms, and so you have to sort of consolidate. So, you know, in order to fix this, someone either has to step into the void, a competitor or another healthcare providing organization, or the community needs to perhaps encourage Optum to figure out why the doctors who didn't retire, who left OMG, why they retired, and perhaps change some things so that it becomes a more attractive place for providers to care for all of you.
That's all the time we have for today. Please join me in thanking our panel. This has been our June 28th conversation at the City Club of Eugene. In honor of America's 248th birthday next week, we will not be meeting, but we'll be back in 2 weeks' time, July 12th, right here in the Maple Room for a program on public safety in downtown. And for those of you wondering, when's part 2 of healthcare? It's the following week, July 19th, so hope to see you all back here then. Thank you for joining us, and good luck to the heroes at Hayward. We'll be pulling for you in Paris. Thanks very much.